Okay. I'm trying to. Okay. Y'all would think by now I would have this Zoom thing all worked out. Okay, so y'all can hear me okay?
Yep, we can hear you.
Okay, and y'all can see my screen okay?
Yes, ma'am.
Okay, cool. All right. All right, guys, welcome to Skin and Soft Tissue Infections. How do I advance my slide?
Hey, Becca.
Hey, AK!
I'm here.
I just did that urine sample for that patient that brought it in.
You are glorious. I appreciate you.
Okay, so skin and soft tissue infections. So apparently Dr. Norton's going to give y'all a derm lecture tomorrow too. And so him and I were talking or texting this weekend about what's he going to cover and what are we going to cover. And so I wanted to just go heavy with just straight up skin infections and soft tissue infections. Most of it comes from the Spectrum app. And then he asked if I was going to do like things like measles and whatnot. And so no. So anything exanthem or enanthem or more systemic, I won't cover. Happy to take questions. And so yeah, so that's what I'm going to try to go. I think it's going to be a super fast talk. So I'll try to speak very slowly. This is basically the objectives right here. So talking about infections in your epidermis, dermis, and fascia, and then the subcutaneous tissue. I actually kept it above the deep fascia, being true to skin and soft tissue. So I didn't cover pyomyositis or myonecrosis. So if you're here for that part of the talk, I'm really sorry. And then also going along the lines of the Spectrum app, we have some things on zoonotic skin infections and then surgical site infections. And then I just kind of a couple of other little pearls on some viral and like one or two fungal things here and there. Okay, if you want to follow along in your Spectrum app, you're welcome to. Shout out to our PharmD doctors, Andy and Rob, for that. The Spectrum app, so what I was also basing all of this talk on is mostly from the IDSA skin and soft tissue article or guidelines, which is also correlates with the Spectrum app as well. And I was hemming and hawing over this talk about how best to organize it, if it should be layer of skin or bacteria or purulent versus non-purulent. And I wanted to do a Jeopardy. I was hemming and hawing. So anyway, this is what we got. So we're gonna go by starting off with the non-purulent things. So erysipelas and cellulitis. These are the things that don't make pus. I'm trying to figure out, guys, how to make this. I don't know if I can see y'all raise your hand in case y'all have questions. So if you have a question, just unmute and shout out. Okay, so non-purulent things. Your erysipelas and cellulitis. P.S. Some people around the world use these two terms interchangeably. So if you're confused what the difference is between erysipelas and cellulitis, don't worry. They're really basically the same. Just erysipelas is your more superficial and cellulitis is a little bit more deeper. Clinically, classically, erysipelas has more defined borders, and then cellulitis has more blurry kind of borders, but they're both group A strep. They're both superficial, and yeah, your blood culture is hardly ever positive with these. That's all I have to say about this. For your treatment of these are going to be pretty benign, generally speaking. And like I said, most of the time that's going to be group A strep. So you're just going to do a group A strep directed antibiotic. So your ceflexin. That's it. Generally speaking, MRSA loves to make pus, and these are not pus. So MRSA is going to be unlikely. However, if there is a severe infection, i.e. with some systemic signs, or if there is pus, or if there's trauma, and especially for like IV drug use, you do want to consider MRSA during that time, and maybe escalate with some MRSA coverage like vancomycin. If it's a severe infection and it's an immunocompromised person, and you've got more than just cellulitis going on, then vancomycin plus cefepime is what you might want to consider. For mild infections, generally 5 to 7 days. So 5 if it's super mild, 7 days if it's not so much. And then if it's systemic, then you got to fix the systemic problems first and get your patient better, and then consider a duration of 7 days. Elevating the area of cellulitis will help kind of drain that inflammation a little bit. So consider that. AK and Rob and Andy, feel free to chime in for anything to add. Anybody got questions about erysipelas and cellulitis? Okay. So your purulent ones, this is traditionally going to be staph, because staph loves to make pus. So we got folliculitis, furuncles, and carbuncles here, which PS, I had to just by my own curiosity, look up the root of carbuncle. And so folliculitis is just like your little superficial hair follicle. Furuncle is when it gets in one follicle a little bit deeper, and then carbuncle is just a group of hair follicles carbuncle is just a group of furuncles. Makes sense. But carbuncle comes from the Latin etiology of carbon, meaning hot coal. Isn't that fascinating? I'm going to assume that y'all are all shaking your head yes. All right, so treatment of purulent abscesses, furuncles, carbuncles, they're all boils, they're all just abscesses. If it's super tiny, less than or equal to 3 centimeters, you only just need a little bit of an IND, and you don't need antibiotic therapy. That's good enough. Just drain it and you'll be fine. If it's larger than 3 centimeters, then you need to IND it, and then you can add on some antibiotics. Generally, you want to add on some Staph aureus coverage of antibiotics, so your Bactrim as a first line, or consider doxy or Clinda plus cefalexin. Does anyone know why we would do Clinda plus cefalexin in our spectrum map? All right, I got questions later on coming up at the end of this talk, so y'all gotta like look alive out there, look alive. Okay, so our MRSA sensitivity rate to Clinda is really good. Our MSSA sensitivity to Clinda is crappy, 74% sensitive to Clinda, so that's why ceflexin is needed on board for the MSSA. And then, of course, if you've got a pretty severe purulent boil, abscess, and definitely with some systemic symptoms, like more than just fever, but like hypotension and things like that, then go straight to the IV bank. And culture, you got pus there, might as well culture it. It's probably going to be staph, but is it going to be MSSA or is it going to be MRSA? We need the culture to help. And then also just a plug, I think Dr. Birch likes this one too. If your culture grows out a coag negative staph, generally those are going to be just a skin contaminant. However, Staph lugdunensis is a coag negative staph and it loves to make pus and it acts just like Staph aureus. So that is a coag negative staph that we would treat. Right, Dr. Birch? Yay. Questions about purulence? Oh, wait. I forgot. Y'all can also text me if y'all have any questions. Okay. Impetigo. Wait, let me make sure I'm following my spectrum maps good. These are also on algorithm form on the pH formulary. If you need it on a written down form. Okay, so impetigo, we got bullous impetigo and we got non-bullous impetigo. And then also kind of in this group is ecthema, which is just a deeper impetigo. For bullous impetigo, that's usually going to be staph. That's your toxin doing that bullous and it's going to rupture. And see down in that corner, it's going to rupture and leave that little nice, pretty ruptured bulla. It's going to be, like I said, usually staph. The literature actually, the IDSA guidelines, they actually say that most of the time it's going to be MSSA. And so that comes in handy with your antibiotic choice. Non-bullous impetigo, so what we usually see in these kids on their face with that honey-crusted lesion, the honey-crusted junk is mostly going to be strep, but you can have staph there too. We treat these topically with mupirocin, and then also PO cephalexin helps for treatment to decrease transmission, and then that's just going to be like a 7-day course. The mupirocin will get MSSA and MRSA, as well as strep. The cephalexin will get your strep and get your MSSA. Of course, it's not going to get your MRSA, but that's why we said usually these things aren't MRSA and they're MSSA. Ecthyma is just a deeper form of impetigo, but for all of our hemonkers out there, if look in that little tiny little picture down there. Be aware of those little innocuous looking things, ecthyma gangrenosum. So that's a necrotic ulcer that is usually associated with Pseudomonas bacteremia in our cancer patients, anybody who's immunocompromised. So if you see that, you need a blood culture. I'm sure your patient will be acting sicker than I'm making it out to be in just that little picture, but a blood culture and pseudomonal coverage. Anything to add? Nope. Any questions? All right. Necrotizing fasciitis. This is a surgical emergency. This is usually from any kind of penetrating trauma. So surgery, trauma, chickenpox. So a big disruption of your skin integrity. It can be polymicrobial. Think about anaerobes. It can be monomicrobial. Strep, so group A strep is a big one with this. Group A strep traditionally was a big one with varicella, with your chickenpox concern. MRSA, we definitely worry about MRSA with this. And then Clostridium, definitely with your penetrating traumas, also with your surgical site infections can get in and cause Clostridium infections this way. And then your water pathogens, Aeromonas and Vibrio. Early necrotizing fasciitis. Early fasciitis can be hard clinically to discern from cellulitis. Cellulitis is going to be painful and it's not going to be hard. You can mush on it and it will give way. fasciitis is going to be hard, like wood hard. And then you could also have anesthesia with necrotizing fasciitis if you can't feel. That's not cellulitis. You can also have the exact opposite, severe pain out of proportion to your exam, think fasciitis. You would have more discoloration and bruising, gangrene. Definitely the crepitus is what people automatically think with this, which is good. It can track up following the fascial planes, and that would be kind of hard like wood as well. And then of course, you're going to be super sick with this. So systemic symptoms, including shock. This one, like we said in the very first bullet, is a surgical emergency. So your very first treatment should be surgical debridement. And then as a second guess, as a second line, you definitely still do antibiotics. You need broad spectrum antibiotics to cover for anaerobes as well as the gram negatives and gram positives that we just mentioned. So that's going to be your pip/tazo. And then you need protein synthesis. What's the word? I forget the word, but you want to get to the protein synthesis part of the bacteria as well. Classically, that was with clindamycin, and Rob is teaching us now. Linezolid is really super good too. So surgical debridement, and then linezolid plus pip/tazo. And then you'll have your cultures, and then you can narrow down based on your cultures. Anything to add on that? Any questions?
Wait, I was just going to say, it's a common question to get, as Dr. Widener put on here, varicella with group A strep. That is just a common association that you need to know and absolutely can be on your boards. The other thing is you see that pip/tazo is on here, and you should say, well, why don't you do meropenem instead of doing pip/tazo, right? So you got to know why we're doing what we're doing. Because meropenem is also going to get your Ehrmonas, it's going to get your MSSA, it's going to get all sorts of different things. But what you see here is the Clostridium. So you like that piperacillin component for the Clostridium is the penicillin component. So that's why we choose pip/tazo in that instead of something like a meropenem. Anyway, that's all.
Awesome. All right, surgical site infections. This is when I first started this talk out as a Jeopardy talk because, I don't know, I just was feeling very bored doing a normal PowerPoint. So I made this into a Jeopardy. So we got some Jeopardy questions here. Okay, everyone, look sharp. Pick you. I can see you. I can't see anybody else. All right, pick you. Then pick you's answering all these questions. Oh, hey. Well, shoot, y'all already know. Andy can't answer. He knows all these
We're
answers.
ready to win.
All right, surgical site infections can be a source of fever. Okay, P.S. if you want the answers, they're all on your spectrum app. So the person that can most quickly navigate their spectrum app will get the answer. Okay, surgical site infection can be a source of fever generally after this post-op day.
2.
Who said 2? Liz. Okay, I will accept 2. However, good to know in the first 48 hours without drainage, your source of fever will unlikely be from a surgical site infection, and you need to investigate other sources of your fever. But after 48 hours, it can be considered because it's an increasing source of fever, but still not your main source of fever. But after 4 days, surgical site infection becomes equal to other sources to cause fever. So generally after 4 days, but Liz said after 2, which is kind of correct per the IDSA guidelines as well. In our Spectrum app. Let me go to it. Okay, in our Spectrum app, we got fever within 4 days of operation and fever after 4 days of operation. So at that 48-hour window, kind of consider it, but also think more about other sources of fever.
And the easy way to remember this, y'all, is in a surgical setting, you're not going to get many organisms in the wound, right? So doesn't it take days to grow enough organisms to make an infection there? That's why that first 24 to 48 hours is typically usually not infectious process of the actual wound itself. It's because it takes multiple days to grow.
That is beautiful. That's perfect. Yes. Okay, next question. These pathogens should be considered in a surgical site infection occurring within 48 hours post-op. So if you do have a surgical site infection within 48 hours, which pathogens would you consider?
Group A, strep, and Clostridium.
Yes, group A, strep, and Clostridium. Dr. Birch, do you know why those would be sooner? I don't. I'm not pimping my partner.
Did you ask me a question?
Oh yeah.
I'm sorry.
Do you know why group A, strep, and Clostridium are sooner in the course?
Well, I'm sorry. I was responding to a text. So listen, Rob says gas and toxin.
Okay, well that makes sense. Okay, treatment for a surgical site infection on post-op day 5 without any systemic signs will be this. La, la, la.
Suture removal and IND.
Yes, so no antibiotics needed if you do not have any systemic signs and it's after post-op day 4. So, yep. Okay, antibiotic or antibiotics of choice for a surgical site infection involving the GI, the GU, or the perineum. Rob, I saw this also on IDSA, and they threw in axillary surgeries too. So I don't know.
Rocephin and Flagyl.
Wait, what?
Rocephin and Flagyl.
Rocephin and Flagyl. PICU's on a roll. All right, susceptibility rate of Clinda for MSSA at the Children's Hospital.
74%.
What? Susceptibility rate of Clinda for MRSA at the Children's Hospital.
%95%.
What? Yes. So this is just a very good example to shout out how important your antibiogram is. Wherever you go to practice for residency, if you're a med student on here, or fellowship, or if you're going out, graduating residency and going out into the community, check out your antibiogram for your local children's hospital, because those are pretty important. That's a pretty big range in between MSSA and MRSA with Clinda. All right, anything to add for surgical site infections, Ra or Andy or AK?
No, I think you're good.
Okay. Zoonosis. All right, ready for questions? Hannah, oh, wards. I see wards, but there is no video on wards. What is wards doing? Are they all in the resident room smoking? That's why their video's off? Mm-hmm.
You know, smoking these days, see, it's different stuff than when we were in school, what smoking was.
Mm-hmm. And I don't see I don't even see clinic on here. Usually, oh, clinic's got their video off as well. No telling what they're doing. All right, zoonosis, common human bite pathogen. Also, the E in haystack.
Echinacea. Right?
What's that?
Echinacea.
Eikenella carodens, yes. So a gram-negative, common to the nasty, dirty mouth of humans, commonly causing skin and soft tissue infections from a bite. And be careful with punch wounds because you know it'll get in that fascial plane and really mess you up.
And so this is one of my favorite questions, and it irritates me to ever, like, it's one of my big pet peeves, right? So this is why I hate clindamycin for aspiration pneumonia as well, right? So what drug does not cover Eikenella? This will be a question on your test. I had it on my boards.
Ooh.
That you would think would be an okay drug to use during this time, both in aspiration pneumonia and in skin and soft tissue infections.
I'm guessing you Clinda.
Augmentin.
No, it's Clinda. So Augmentin is the drug of choice, or it can be. So it's clindamycin. That's why I hate clindamycin for aspiration pneumonia. And because there's plenty of times that you miss it, but in addition to that, it doesn't catch it in mouth bites as well.
What's that, Rob? What's that anaerobe, that mouth anaerobe Peptostreptococcus that it's resistant to?
Yep,
Is that the one?
that's right as well. That's why we like Augmentin.
Okay.
Augmentin or Amsulbactam is the drug of choice for anything mouth.
Next question. This bacteria from a cat scratch will cause rapid cellulitis.
We need some answers from clinic and from the wards, please.
Pasteurella.
Pardon? What'd you say, Liz?
Pasteurella.
Yeah, Pasteurella. So this one I threw in kind of a trick question to this, because remember, cats, they lick their paws and they clean themselves, and so their Pasteurella will also get on their claws too. So you get Pasteurella from cat and dog bites, but also cat scratches as well, and that's rapid cellulitis. So cellulitis within 24 hours of your bite will definitely be Pasteurella and not staph. If you get, or strep, if you get cellulitis at like a couple of days later, that's going to be more your strep and your staph. On the spectrum map, there is cat scratch Bartonella as part of your skin and soft tissue infections, but remember that's just going to be like a papule or a nod, or like a little node or a papule, and not cellulitis. Like how I tricked it up there? All right, good job, PICU. You're my favorite residents ever so far. Hear that, clinic? Hear that, wards? I don't know, because your video is not on. All right, the duration needed to treat most bites.
$5 days.
Yes, 5 days. Oh, you know what? I'm not even doing, look, my little pretty little things. Okay, 5 days, yes. All right, amoxiclavulinic acid or Amsulbactam is needed to treat bites to cover for these pathogens, which we kind of just said, so.
Shout it out.
So we need to hear from some other people, please. I'm going to start calling out names. I see Hannah Rugg is on here. Alyssa is on here. There's some other people.
I'm telling y'all, this is a fast talk. This is why I have to wait for questions.
Chelsea.
Who's that? Is that Mason? Hey, Mason.
And Keith.
Wow.
Oh, who's that? My camera's in the way. Who's in
All
the
right,
picture
pick
now?
you. What's the answer?
Anaerobes.
Yes. So skin flora, because the bite's going into your skin, so your gram positives, but then also the junk in the mouth, so the anaerobes and the gram negatives. Okay, this one fun. It's not on your Spectrum app. The pathogen of a poorly healing nodular lesion that you would get from a fish tank.
Mycobacterium marinum.
Yeah. I don't even know if I spelled it right. Yeah, awesome. So that's so anytime you've got this nodular lesion, usually on your hand or your forearm because you're in the fish tank, and it's not healing up, think about Mycobacterium marinarium. Okay, this one is also not on your spectrum map. Capnocytophagia is one of my favorite. Capnocytophagia is a gram-negative rod that can cause a skin infection from a dog bite, but you hem-onc fellows out there, it's especially important in what population as it can cause fulminant sepsis?
People who are asplenic or functionally asplenic, so like sickle cell.
Yeah, who said that?
Ashley.
Awesome. Yeah, so asplenia, capnocytophagia can cause fulminant sepsis if you have no spleen from a dog bite. Which leads me to the teaching point of prophylaxing for human and animal bites. You don't always have to prophylax, but you definitely want to consider prophylaxis for any human bites because we are dirty, dirty, dirty. Bites to the face, the scalp, the genitals, the hands because of the fascial planes, immunocompromised population. If you can't get a good washout of it. And then bites from dogs usually are kind of somewhat more clean, but if it's a large laceration or like a crush injury, or those locations we already mentioned, and then usually cat bites because they're, I don't know, I'm a cat person, so I'm not going to talk bad about cats, but their mouths are kind of dirty.
And they penetrate.
Yeah, the puncture.
So one question that I have for people is, once you get a dog bite or a cat bite or any other animal bite, what other things do you need to consider that's in the infectious disease world to do for your patient?
Ooh, that will be on your boards.
Rabies.
Do what?
Rabies.
Yeah, so you have to absolutely think about rabies. And then the other thing you need to do is to make sure that they're up to date on their tetanus vaccine, okay? But the rabies, always, you should think about that. Dog and cat and other animal bites are reportable. So you need to report that in the ED and also in the clinic areas. And then the way that this goes, and I just get these questions all the time, so I'm going to tell you how it works, at least here in South Carolina, is that if the animal is able to be obtained and can be monitored, then that is preferred. And you do not have to start rabies prophylaxis if you have the animal and you could do observation. Those animal observations occur for 10 days. That's actually 5 days longer than what is needed to actually kill an animal due to rabies. And that's just more to be sure that the animal really doesn't have rabies. So as long as you can observe it, that's great. If you cannot observe it, and then most of the times we do initiate rabies prophylaxis. Usually only hospitals or urgent cares carry the actual PEP and the vaccine. You have to do both. And so that's unfortunate because a lot of times you have to bring them back to the emergency room to continue their series. The other thing is that no matter what, if you have a pretty big bite to the face, if you don't know if the animal was caught or not caught and the kid comes into the hospital, that is one area that you want to go ahead and initiate rabies prophylaxis right away. The reason being is that once rabies goes into the peripheral nervous system, it takes so many days to weeks to actually go up the peripheral nervous system to get into the central nervous system. But if you have a bite that is around your face that's easy to get into the central nervous system, it happens pretty quickly. So you want to go ahead and prophylax for that.
Awesome, because rabies definitely, like she said, will be on your boards. Are there any questions so far? I can't see the chat box, so I don't know if there's anything there. No? Okay, I think that's all for our questions. That's all for our Jeopardy. All right, so this is just, now we're completely going off the spectrum map. So Rob or Andy or AK, is there anything else on the spectrum map that y'all wanted to talk about, or on the algorithm or the pH formulary?
I don't think so.
Okay, so I just wanted to throw in a couple of viral things. And like I said, I'm not doing exanthem, so I'm not talking about measles or nothing like that. And I feel like there's even more I started going down rabbit holes of things I could / or could not include. But these were some things that I've seen. And so just kind of some pearls here and there. And I didn't want to go in, I actually didn't realize how short this talk was, so I didn't go into these in great detail, but just wanted to shout out a couple of little things here and there. Okay, so your viruses, most of your skin soft tissue infection from viruses are going to be your herpes viruses. So I didn't feel like talking about herpes simplex because I feel like we all know about it. So complications of herpes simplex would be eczema herpeticum. And I feel like we have seen much of this over the past several years. So I feel like at least our second and third year residents are pretty comfortable identifying and treating eczema herpeticum and knowing what that is. But for our interns, if you haven't seen it yet, there's a beautiful picture. The one that the A is on is a stock picture. The one that's next to it at the neck is one of our patients that we treated here a couple of years ago. That was a grappler, Dr. Birch, which is a combination of wrestling and martial arts. So eczema herpeticum, you see this in patients who have underlying eczema, usually poorly controlled, or like not poorly controlled, but like bad eczema. It can be hard to distinguish from poorly controlled eczema. However, just like the pictures, so your skin integrity is compromised from the eczema, and then you just get herpes on top of that. And because the skin's bad, the herpes goes crazy. So you get these crusted, or I've hardly have ever seen vesicular with eczema herpeticum, but you can have vesicular with the herpes, crusted, ulcerative kind of look to it, painful, definitely. You can get a super infection on top of that, so you can get impetigo on top of it. So if you see this kind of nasty thing and you got a history of eczema, think about eczema herpeticum. Also up in the herpes, in the HSV world, is herpes gladiatorum. So this is going to be in your wrestlers generally, but because wrestlers and gladiators, right? And so they like to share headpieces and earpieces. And so it can cause these outbreaks among wrestlers. And so they're sharing these earpieces and headpieces, and then they're getting down on the wrestling pad, and like, it's all this skin to skin contact. So there you go. You would have to treat the actual herpes infection, and then also look for outbreaks among the team, and then also probably do some suppressive acyclovir dosing throughout the whole wrestling practice and performance season, or whatever you call it. Anything to add, AK, about herpes simplex? Or any questions about those?
Make sure it's also, I mean, with the gladiatorium, when it goes to a wrestling group, which you will maybe see, you got to make sure too that you're giving good education with cleaning the mats with bleach solution and all those kind of things, because that's a fomite.
That's right. That's right. All right. Also in our herpes family, we got VZV. So we got varicella, which is your chicken pox. I feel like everybody knows about chicken pox. We might not always, we probably hardly ever see it, but I feel like we already know about it. So your primary VZV infection. So you'll have systemic symptoms. Your skin infection part of the virus will be disseminated. And I don't know, you'll usually have cough and congestion, and you just won't feel well. However, we vaccinate for this. Because we vaccinate, we don't see as much of it. And when we do, it looks differently than it used to look You can get breakthrough disease. Generally, a breakthrough chickenpox disease will be anywhere outside of 42 days after your vaccination. And it can look very subtle. You can have less lesions. You can have just a couple of lesions, and your systemic signs won't be as prominent, or it could. So there you go. Your complications of varicella, you definitely want to look for impetigo, necrotizing fasciitis with group A strep, like we already mentioned. And then you can get MRSA bacteremia. Dr. Birch had a horrible case several years ago of MRSA, very stubborn, persistent MRSA bacteremia that landed in the hip, that started from varicella in a toddler that was not old enough yet to get vaccinated. Is that right?
That's correct. So the point there is the fever never went away. Varicella fever should go away by 7 to 10 days. And if it's after that, something else is wrong.
And then classically in your textbooks and your boards, this is the lesions of varicella, of chickenpox, are going to be in different stages. And it's respiratory and contact, airborne and contact precautions.
What's the organism you have to worry about getting secondarily infected with if you have varicella? I already said it in this presentation.
Yeah.
Anybody?
Martha?
Group A strep.
Yeah.
Yep.
Yeah. MRSA, whoever said MRSA is also one of those, because like I said, we just had that bacteremia with MRSA, definitely, but then group A strep for the impetigo, the necrotizing fasciitis.
And that, again, that could definitely be on your boards. And so they're going to, if they ask you that question, they want you to answer group A strep.
Yeah. All right. Also in the VZV, so now we got zoster. So zoster is just chickenpox that's hanging out in your body and comes out at a different time. So zoster, we do see this even more rarely, but we do see this in kids and teenagers. You can get zoster even though you've been vaccinated for chickenpox. So you can have vaccinated associated shingles, basically. Does that make sense? You can also have wild type zoster, and even if you've been vaccinated for chickenpox, you can have wild type zoster. And the thought is maybe you had this chickenpox prior to getting vaccinated, and then now you've got zoster. Can you follow my hands for that? So zoster is gonna follow your dermatomes, and classically. Clinically, if you've got something on the face or even on the body, zoster does not cross the midline. So that's why I really liked the pictures in D, even though they're old people. Look how beautiful that is on the face and on the lip, not crossing that midline. So if it doesn't cross the midline, you're dealing with usually zoster. Questions about zoster? Okay. I feel like I get a lot of calls, I don't know about Dr. Birch, from the community about grandma with shingles. Can they be around the kid? And so these, as long as it's covered, you're good. It's contagious until they crust over. But if you can cover it, then you can be around the kid. And then the last viral one I just threw up was molluscum. This is our only pox virus that we see nowadays. And so it's not in the herpes family, it's in the pox family. And so it's gonna look different. Look for these umbilicated. See in that picture how nicely umbilicated they are? That's gonna be your molluscum. Otherwise, they're benign. Unless they are skin to skin transmission, and so you can have genital molluscum, and so you need to treat the genital stuff so you don't sexually transmit it. Otherwise, you don't have to treat them. They are skin to skin, but they have a low infectivity rate. And if you do treat them, usually it's more of like a physical treatment with freezing them or like digging out the core, which I've never heard, but I hear is so satisfying. Okay, any questions about those? All right, 2 more slides. I got fungal, I just wanted to mention these 3 fungal ones. I think Dr. Norton tomorrow is going to talk about tinea, but this was a great, really quick case that I had for tinea that I just wanted to plug because it's a very nice little pearl. So if you have ringworm and you treat it with steroids, which of course is not the treatment for ringworm, but if it is treated with steroids, it's going to alter the appearance of it. And so now your tinea capitis is going to turn into tinea incognito. And then it can further go down into the deeper dermal layers and get this nodular appearance, and that's Majuchi granuloma. So this was a case I had of started out as ringworm, but it was diagnosed as eczema. And so this poor teenager was told to put steroid cream on top of it for the longest time, and it wasn't making this eczema any better. And then the eczema was getting worse, and that's her leg as it progressed. And then that last picture is her calf when I saw her in my exam room. And this is when they teach us, I think it's brilliant when it comes back around. They teach us, in med school that diagnosis is 80% your history, right? So I had no idea what this rash was. And this mom was showing me these pictures. And then the mom and the teenage patient, they told me, they're like, we really think it just started out as ringworm, because they did not have an initial picture. And they're like, it really started out looking like ringworm, but they said it was eczema. And so that's when I went back to my book and I was like, ringworm, when you treat it with steroids, causes this nasty skin, soft tissue, deeper infection. So I gave her some, I think griseofulvin or maybe some itraconazole, I can't remember. And she cleared right up, and they thought I was a hero, even though they're the ones that diagnosed it. So just keep those in mind. The sporotrichosis that I misspelled, I haven't clinically seen this ever, but I thought it was a nice little pearl to clinically keep in the back of our minds, that it doesn't always have, this is your classic rose thorn that follows the lymph node chain up, like in picture B. But a nice little clinical pearl is that in kids, usually it doesn't follow the lymph node chain, and it can just be a solitary crusted papule or nodule, just one and not a chain. Good to know, I thought. And then blasto, I just wanted to do a quick note on blasto, since we recently had a blasto patient with he had respiratory symptoms. He had no skin findings, but just remember blasto can do respiratory or skin, and the skin can be usually this ulcerative nodular solitary lesion, and we are in a blasto area of the Southeast, so that's blasto.
Yeah, and on the test, they're going to give you a pneumonia with an ulcerative skin lesion. That's how you're going to know it's blasto. They'll make it pretty easy for you to choose blasto.
Yeah, and maybe in the Mississippi or Ohio River Valley.
Yeah.
And this is the last slide. So this is parasitic. So these are just, I've thought about these because I saw them. So I thought, well, that's good. So scabies, we all know about scabies, and I don't want to spend any more time talking about scabies, because y'all know it's really itchy, and y'all know in clinic, y'all see this all the time, and y'all know how to treat it. What I didn't know was in this little picture A, this was my patient that I saw. He had on he's a little baby, and he had these little solitary. So nothing in the folds, and nothing that you could see the little travel path of the scabies, right? Things that you're classically taught. So in babies, scabies is more just these vesicular lesions, these little spots that are itchy, and they're not going to be in the folds, and they're not going to be in the locations that we're used to. They're going to be more palms and soles. This one was also brilliant in that history diagnosis is 80% history. So this little baby had made several trips to some ER and was never diagnosed with anything. And so finally the PCP sent them my way for this rash that wasn't getting better on her feet. And I'm just sitting there talking with mom, and I'm watching mom, and mom's sitting there itching as I'm taking a history. I was like, Mom, what's going on with your itching? She's like, oh, I've got scabies on my hand and it won't go away. I was like, oh, I think that's our diagnosis. So we treated the whole family and then they did fine. So just remember, scabies in babies looks different. Scabies in babies, I like it. And then cutaneous larva migrans, that's always a fun textbook one where you see this beautiful however you say that word, serpendigenous worm pathway. Super itchy. It's a hookworm from dirt and soil, so it's usually on our feet. It is self-limited. You don't really have to treat it, but we do. I had a fun case that I could not get a picture of because it was a 2-year-old and he had cutaneous larva migrans on his 2-year-old little penis. But mom came in. They live on a farm. She already knew the diagnosis. The poor kid had already been treated, and he got it on his penis because they play in the trough that you have the water for the horses to drink out of. They play in that all the time too. So it was kind of a fun little case. But it had already been treated and he wasn't itching anymore. So that little pearl is just to know that scar tissue of the worm track, of the hookworm track, can persist for months after treatment, and it's fine. It'll go away eventually. That's all I got. That was fast.
Yeah, but it's perfect time because it's 1:15.
Look at there. Anything to add, AK or Rob or Andy, or any questions, or do y'all, or even the residents, if y'all have any fun infectious disease skin rash stories? Not personal ones. You can keep those to yourself.
Sounds
you're
like
good?
that's a big fat no.
Okay. Well, thanks, guys.
Thank you so much.
Mm-hmm.
Bye.
Thanks, PICU. You're the best.
Bye.